Good afternoon, everybody. Thanks for joining us in our cardiovascular groundhouse. Welcome, Dr. Albert, and thank you for being with us today. My name is Lorena Telles. I work at La Cardio, and it's my pleasure to introduce to you our moderator for this event, Dr. Luis Carlos Sáenz, Director of the International Arrhythmia Center. Welcome, and thank you for moderating this event.
Muchas gracias, buenas tardes, bienvenidos a todos los participantes. Mi nombre es Luis Carlos Sáenz y les estaré acompañando en la moderación de esta conferencia. Les recordamos que al conectarse a la misma, usted autoriza el tratamiento de sus datos personales, los cuales serán hechos de acuerdo a la Ley 1581 de 2012 y nuestra política de datos personales, la cual puede consultar en www.cardioinfantil.org. De igual forma, le informamos que esta conferencia está siendo grabada. El chat de preguntas se encuentra habilitado en la barra de participantes. Les agradecemos dejar allí sus inquietudes, las cuales resolveremos al final de la sesión. Enviamos un agradecimiento especial a la empresa Medtronic por vincularse como patrocinador exclusivo de esta actividad. Hoy tenemos el honor de contar con la participación como expositora a la doctora Christine Albert, con la conferencia Prevention and Early Intervention for Atrial Fibrillation. Dr. Albert received her medical from Harvard Medical School and MPH from Harvard School of Public Health. She completed her internal medicine, cardiology, and cardiac electrophysiology training at the Massachusetts General Hospital in Boston. Dr. Albert is a professor of cardiology and the chairman of cardiology at Cedars Sinai Medical Center and serves on the editorial boards of Heart Rhythm and Circulation. Dr. Albert is a visiting professor at Harvard Medical School and an epidemiologist at Brigham and Women's Hospital. She's the immediate past president of the Heart Rhythm Society, and Dr. Albert has authored over 250 papers. Welcome, Dr. Albert. You may start.
Well, thank you, Luis. It's a pleasure to be here. I'm going to share my screen. And I think I need to be allowed to share. One participant may share the screen at a time. Okay, let's see if I can try this.
Sorry, Doctor, are you able to? Oh, yeah.
Now I was able to. Yeah, I changed it to multiples, so I'm good. Thank you. All right. Well, like I said, it's a pleasure to be here today. And what I'm going to talk to you about is prevention and early intervention of atrial fibrillation. These are my disclosures. As you all know, the global incidence of atrial fibrillation is quite large, and there are some geographic variations, with the highest incidence being in North America. But overall, 33.5 million people worldwide are afflicted with atrial fibrillation, estimated in 2010, and even greater in more recent estimates. And there's a projected prevalence of atrial fibrillation is markedly increasing. And these are just some estimates up to 2050. There could be as many as 15 million people in the United States alone with atrial fibrillation. We know atrial fibrillation increases with age, and this is incidence rates. And you can see how there's this exponential increase at 60 years of age for atrial fibrillation. And this has implications for our screening that we'll talk about in a bit. And also, we don't even know really the whole prevalence of atrial fibrillation because that's just clinical atrial fibrillation. And there is this whole possibility of subclinical atrial fibrillation, which we'll talk a little bit about in a minute. And the estimates vary. If you take recent handheld ECG screening tools in people over age 75, it may be as much as 3%. And this is from the stroke stop study over here. So you can increase from 9% to 3%. If you go to people who are over age 75 with one stroke risk factor, you will come up with about 7.4% will have atrial fibrillation just detected on screening. And then if you take patients with cryptogenic stroke or multiple risk factors, you increase that even further. With cryptogenic stroke with an ILR, it's about 16%. And with multiple risk factors with ILRs, it can be up to 30%. So really a lot of atrial fibrillation that goes undetected. And again, these are just some of the studies looking at that. But in general, the majority of atrial fibrillation, this is from one study, Reveal AF, the majority of this tends to be very short duration. When you actually look at atrial fibrillation that's greater than 6 hours per day, which may be the most clinically relevant, that is a lower amount of atrial fibrillation over time, but still not insignificant in this population with risk factors. So how do we detect atrial fibrillation in order to intervene early and also to look for prevention? Well, there are multiple methods, including, as we know, Zio patches, the Medtronic patch, iPhone patches, and now Apple Watch. And this Apple Watch study, which I'll talk a little bit about, was done in a younger population and found that 0.5% of the population ended up being notified for atrial fibrillation. And so when you followed it up with one of these patches, it was about 34%. And this is looking at those results and looking at it over age range, the number that actually were notified and then actually had atrial fibrillation detected, just so you could get an idea. And you can see that overall it was about 34%, but it varied by age, such that in the younger age group, it was much less. And it was also greater in men versus women. So there are some false detections, and it's also sometimes with patients, we may not be capturing it when we do a 2-week patch. With respect to the positive predictive value, how often on an Apple Watch do you actually have atrial fibrillation when your Apple Watch tells you that your heart rate is irregular? And that's how basically it's done through PPG analysis. And in this Apple Watch study, when people had the patch on and also had notifications on their watch, the positive predictive value overall was around 0.71%. For a positive tachogram and 0.84 for ECG on the patch. And then it didn't actually increase that much for people over age 65. And that's because there are a lot of other things that can cause an irregular heart rhythm in people over age 65, like PVCs and AV block. And this was also reported on later by the investigators. So in addition to the Apple Watch study, there's also been the technology that was published in the Y-Way study. And again, here looking at about a positive predictive value of 54%, so a little bit higher. And again, looking at when there's a detection, the number that actually have AF detected and identified varies by age. So again, your yield is going to be higher in an older population. So how does this add to what we do in the office? So this is a study that was presented at AHA last year, I believe, and basically the VITAL trial where they actually added these monitors to an outpatient practice, and they didn't find any difference in overall detection of atrial fibrillation, suggesting that at least in the United States, that we're doing a pretty good job in the office of detecting atrial fibrillation. But there was perhaps some suggestion that there could be a benefit in those who are very old. So again, that may be a benefit. In addition, the recent Stroke Stop study was published, which actually used that monitor. So the study that I quoted before that showed that 3% and then 7.5% with those over age 75, reported out the results on heart outcomes. So we can detect atrial fibrillation, but what difference does it make to the outcome? And so this was 28,000 individuals who were followed, 75 to 76 years of age in Sweden. They were randomly assigned to screening or a control group, and they were given a handheld single lead ECG 2 times daily, twice a week. So for 2 weeks. And AF detected was referred to a cardiologist. And they used a combined endpoint that was much broader than just stroke, but ischemic hemorrhagic stroke, systemic embolism, bleeding, leading to hospitalization. And they followed these participants for 7 years, so really extensive study. And as you can see, overall, the invitees with atrial fibrillation and the controls with atrial fibrillation had the same, a little bit more anticoagulation happened for those who actually had atrial fibrillation at the start of the study. And then when you look at the actual screening, there really wasn't that much more anticoagulation started in the population. And it may be because there's also was anticoagulation, and you can see here, started in the control population as well. So again, a lot of education about starting anticoagulation for atrial fibrillation. And the results for the primary composite outcome were significantly reduced. So there was a very small, modest 4% reduction in this combined outcome of ischemic hemorrhagic stroke, systemic embolism, major bleeding, or death. When you look at stroke, it was reduced, but not significantly so. In addition to this study, another study that puts a little bit of a damper on the idea of screening and detecting undetected AF is the LOOP study, which is a smaller study, but still quite large, about 6,000 individuals. And this study had a primary outcome of stroke or systemic embolism. And again, it was reduced, but not significantly. But again, maybe in a larger sample size, you would have found a reduction. And the rest of the endpoints were not reduced. So the idea is that, clinical atrial fibrillation is really what we know about these days that actually can be treated with anticoagulation and prevent stroke. There was one part of the study, again, whether there may be certain subgroups who might benefit from screening. And so this is looking at systolic and diastolic blood pressure in the LOOP study. And those who had high systolic and diastolic blood pressure seem to have more of a benefit. So likely, maybe targeted screening with ILRs in certain populations might be a benefit. So really, let's go back to clinical AF, because that's what we know about today that really makes a difference with our treatments. And so we know that clinical AF is associated with a 4 to 5-fold increased risk of stroke. It accounts for 25% of all strokes. There's also an increase in dementia equivalent to the presence of stroke. There is a marked increase in heart failure. It's actually the strongest risk factor for heart failure. There's an increase in myocardial infarction. There's also a 60% increased risk of coronary kidney disease. And actually that's been borne out by some Mendelian randomization studies recently, suggesting that AF may have a causal relation to kidney disease. And then there's also an increased risk of cancer that has been shown in several studies now. Again, whether that's a causal association or not is unclear. So putting this all together, there is an elevated risk of mortality in patients with atrial fibrillation. And this is a study we did about 10 years ago in women who had no prior cardiovascular disease. And even in this low-risk population, there was a 2-fold increased risk of mortality, specifically cardiovascular mortality, but also non-cardiovascular mortality in patients who had atrial fibrillation. And we haven't made much of an impact on mortality. If you look at, these are data from Olmsted County, and again, this is ending in 2000, but I'll show you some from Framingham, which is more recent. You don't see a benefit on mortality. You don't see a benefit over time on heart failure. We did make a benefit on stroke with our oral anticoagulation. And now that we have the novel anticoagulants, which are more beneficial than warfarin, one would think that perhaps we might see more benefits on some of these things, like stroke and intracranial hemorrhage. But when you look at the actual proportion of types of death in these oral anticoagulation trials, the vast majority, the minority are vascular causes, such as stroke, and the majority are actually other cardiac causes or non-cardiovascular causes. So this is what we can probably do something about with our oral anticoagulation, but these other causes that perhaps are related to atrial fibrillation are not probably going to be impacted by oral anticoagulation. And again, like I said, as far as the mortality results, this is from Framingham, and you can see here there was a benefit. There was moving the needle that occurred from 1972 to 1986 in the study. But after that, there hasn't been much of a change, really. And even when you adjust for time-varying covariates here, you don't see much of a change even from that earlier period. So we need to have, we haven't moved the needle that much on mortality. And you can see the trends in excess mortality in those over age 45 in all of the time periods, showing that there's more mortality in patients who have atrial fibrillation. So the problem is that our current approach to AF treatment is really just wait and see. We wait for it to become clinically apparent and treat. And we've talked already about screening and the fact that there isn't really that much, evidence right now that these short durations of atrial fibrillation treated with anticoagulation. Now, again, there's lots of other things that you could do, might have a benefit at this point. And so our current pharmacologic invasive treatments for maintaining sinus rhythm AF also have significant risks and are often used late in the disease course. And although anticoagulants significantly reduce the risk of stroke, these agents do not entirely eliminate the elevated risk of stroke in those trials and do not impact other causes of morbidity and mortality, as we've discussed. And again, AF, even long duration AF is often silent, and complications may be the first manifestation. It can be missed on a short screening procedure. And a significant fraction of people actually present with persistent AF, and we've learned this from recent studies, almost a third at the time of their diagnosis. And again, they have a worse prognosis and also are more difficult to treat. So that's why I think we need to move to sort of thinking about it in either primary prevention or really intervening early to prevent progression of atrial fibrillation. And so over the years, over the last decade, there's been a number of studies looking at modifiable risk factors that influence AF risk. And so like coronary disease, really, we should be thinking about this in all of our AF patients. And so again, if you do a screening for AF and you find AF and maybe you modify all these risk factors, you'd make a bigger impact than necessarily starting anticoagulation. So risk factors that are strong are blood pressure, weight, sedentary lifestyle, alcohol, smoking, diabetes, and sleep apnea. And you can see in this one study by Marco Perez, the proportion of AF that might be accounted for by all of these risk factors in a population of US women. And it looks like hypertension and overweight are really the biggest piece of the pie. And that 50% reductions in AF risk would be associated with optimal AF risk factors. And it's not even just hypertension. I mean, if you look at several studies, including this one that we published some years ago, it shows that if even lower normal blood pressure, high normal blood pressure, systolic blood pressure, is associated with elevated risks of atrial fibrillation, both systolic and diastolic. So again, maybe we should be a little bit more aggressive about lowering systolic blood pressure in patients with atrial fibrillation. In addition, multiple studies really demonstrate a causal association at this point between BMI, weight, and atrial fibrillation. And we did this study looking at a number of cohorts, and this is observational estimates. So in other words, looking at what patients reported as their BMI or their weight and the risk of atrial fibrillation. And when you see in epidemiology something very consistent, and if you look down here, this is probably one of the most consistent associations, often you think that it's true, like smoking and cancer. And in addition, and so this estimates that 1 kilogram of body mass index is associated with a 4% increased risk of atrial fibrillation. And now we often use genetics to try to get at whether this might be causal. And so you look at the genes that predict BMI, that are associated with BMI, and then you see, are those genes associated with atrial fibrillation directly? And in this study, they were, and there have been multiple replications of this, such that for this study with genetics, the causal estimate was that there might be a 9% increased risk of incident AF. Per kilogram per meter squared. So the effect may even be larger than what we assume from just measuring body mass index. So what about changing BMI? So if we lose weight, do we think that we can lower risk? Well, this study done by Usha Tedrow in the Women's Health Study definitely suggested that, in that we showed that those women who reduced their BMI to less than 30, who had been over 30 or obese, had the same risk as those women who were not obese. And if you look here, If they increased their weight or they stayed obese, they had a higher risk. So suggesting that if you lose weight, now if you look, it's actually quite small, the number of women out of 24,000 that actually did lose weight. So it's easier said than done, for sure. In addition, we've shown and others have shown that obesity really is related to presenting with persistent atrial fibrillation. And Dr. Sandhu, who's here with us now, basically showed this in the women's health study as well. And exercise in obese patients will probably have an impact, because this work from Marco Perez and the Women's Health Initiative shows that if you look at obesity and exercise and you put them together on a scale, so for the obese women, if they exercise more, and this is going in this direction, then they have a lower risk of atrial fibrillation. And the two are synergistic with an interaction of 0.03. And in addition to those data on exercise and body mass index, there's also strong data that alcohol is associated with AF, and recent studies this year as well showing this, that about a drink a day are associated with a 8% risk of atrial fibrillation. And the largest study was published this year in the European Heart Journal, and again, showing that there really didn't seem to be sort of a threshold. We had found previously that there was a threshold around 2 drinks per day, but if you combine all of the studies together, you start to see these very small increased risks at low levels of alcohol consumption. One of the good pieces of news for our patients is that caffeine does not appear to be associated with a higher risk of atrial fibrillation. So again, we often tell patients not to drink coffee, or they hear that from their primary care doctor. Really, there's no data. And in fact, we and others have found a suggestion of maybe a smaller risk in a lower risk in those who drink moderate, small amounts of coffee. And then there had been some studies looking at fish intake and atrial fibrillation, observational studies. And honestly, the results were all over the map, with some studies suggested that people who ate omega-3 fatty acids or fish had lower risks of atrial fibrillation, with other studies suggesting that they actually had higher risks of atrial fibrillation. So this prompted us to actually examine this in the Vital Rhythm study, where patients were given omega-3 fatty acids randomized, and I'll present those results to you in a little bit. Now, wasn't the results on omega-3 fatty acids were also put forth because of some antiarrhythmic actions of omega-3 fatty acids in cellular and animal models. So besides the observational data, there was this. And so a number of investigators actually looked at it in patients who had atrial fibrillation as an antiarrhythmic drug. And so these is a meta-analysis of all these trials looking at recurrent atrial fibrillation and looking at postoperative atrial fibrillation. And although the results are disparate, when you put them together in meta-analysis, there did not seem to be a benefit of treating patients who have atrial fibrillation with omega-3 fatty acids in short-term studies. So we wanted to see whether, if you gave it over the long term, because omega-3 fatty acids also have potential impacts on autonomic remodeling, on fibrosis, other things, so that they could potentially have a longer term impact. So this was the VITAL trial that we published this year. And it was a trial of 25,000 men and women in the United States, double-blind, placebo-controlled, randomized trial, tested in a 2x2 factorial design, 2,000 units of vitamin D3 or 840 milligrams of omega-3 fatty acids with a ratio of 460 EPA, 380 DHA. And for inclusion, men were required to be at least 50 years of age, and women were required to be at least 55 years of age. And all had to have no prior history of cardiovascular disease or cancer or atrial fibrillation. And this was a pragmatic male-based design. We followed the participants all over the country in the United States, and we used baseline and annual follow-up questionnaires, and we mailed them pill packets through the mail, and they reported back on their compliance. And the AF endpoint in this trial was ascertained in 2 ways. We asked the participants whether they were newly diagnosed with atrial fibrillation on each of the follow-up questionnaires. And we also linked them to our CMS claims data in the United States. And then if either of those two approaches suggested that the patient may have atrial fibrillation, we actually went and got the records and confirmed the atrial fibrillation by medical record review. So all of these AF events have been confirmed by medical record review. So this just shows you the characteristics of the study population. The mean age was 67, 50-50 men and women. We're very proud of that. And we oversampled for African-American individuals. Again, because of the vitamin D component, we wanted to be sure there was some data for cardiovascular disease and cancer that there may be specific benefits in Black individuals. And then the hypertension, diabetes, and current smoker proportions are there. So number of incident events that occurred over 5.3 years of treatment were 900. And this was 3.6% of the population. So again, and this is a clinical diagnosis of atrial fibrillation, not screening, had a confirmed AF event. 73% were confirmed by ECG and 27% by medical record report. Again, the type of atrial fibrillation, even in this study where we confirmed the records very quickly from their diagnosis, 38% had persistent AF at the time of their diagnosis. So very likely that people already progress despite not knowing any symptoms at the beginning. And actually, on these patients, 27% had no symptoms. So again, they had to tell you about a diagnosis. They had no symptoms. So that tells you that people are looking for atrial fibrillation. Doctors are now looking for atrial fibrillation. And there were just a small number that were post-cardiac surgery and atrial flutter. And the study had 92% power to detect a 20% reduction, and that's important to point out, or increase in the observed hazard ratio for incident AF. And so what we found is that we did not find a benefit of EPA and DHA. In fact, there was a slightly increased risk that was not significant. And similarly for the vitamin D, the exact same results. I've never had this happen to me before, and the reviewers of the article also mentioned it over, and we checked it over. Exact same results for EPA, DHA, and vitamin D in the study. And then when we look at some secondary endpoints, we excluded AF events that didn't have symptoms prior to randomization. We excluded AF events that were only detected by CMS linkage because there could be some biases to those. We excluded atrial flutter alone and postoperative atrial fibrillation. We performed an on-treatment analysis, and we looked at secondary endpoints of paroxysmal, non-paroxysmal atrial fibrillation, and again, found no benefits in any of those subgroup analyses. And the same for vitamin D. Now, in addition to omega-3s, there has been one study, the PREDIMED study, that did suggest that a fatty acid, actually monounsaturated fatty acids from olive oil, was associated with a lower risk of atrial fibrillation. And I know that there is a group of investigators in Spain that are now currently trying to do this in association with AF ablation to see if this lowers the risk. So what about early intervention in atrial fibrillation? So most of that was talking about preventing atrial fibrillation from happening. And so high-risk patients modifying their risk factors, maybe staying away from omega-3s, which we can discuss a little bit in a minute, and other things to prevent. But early intervention, really, there are several studies suggesting that all those same risk factors will have a major impact even once you develop atrial fibrillation. And these are data from Prof. Sanders' group for weight loss and managing risk factors, showing that you decrease the symptom burden. On Holters, you decrease the burden of atrial fibrillation. So there was a benefit. And Melissa Middledorp, who's here with us at Cedars now, it showed that if you lost weight, you actually could reverse progression of atrial fibrillation. You could stop progression and reverse so that persistent would go to paroxysmal atrial fibrillation. So again, when we think about this, when we see our patients with atrial fibrillation, that weight loss should be one of the predominant things that we recommend. In addition, there are studies, small studies of aerobic training that also suggest that you can lower the risk of atrial fibrillation. And this is looking at burden of atrial fibrillation, time in atrial fibrillation, and those randomized to an exercise regimen versus a control group. See, the control group goes up and the exercise group goes down. And so overall, there was at 17 to 20 weeks of follow-up, there was a reduction in the mean time of atrial fibrillation. Now, what about alcohol abstinence once you're a drinker? We showed that the drinking can precipitate atrial fibrillation, but also if you stay away from drinking after you develop atrial fibrillation, you can lower your probability of recurrence. And this trial was done in Australia and was published in the New England Journal. And it was, as I'm told by the investigators, it was very difficult to do. It was very difficult to enroll because patients don't want to abstain from alcohol. It's not easy to do, but obviously it can be beneficial. And then also besides risk factors, there's data that just some of the treatments that we give for heart failure, for coronary disease, all can have a benefit on atrial fibrillation. And this is in the RACE-3 trial, where they actually used targeted therapy versus conventional therapy and showed that you were more likely to be in sinus rhythm if you were treated with these drugs that I talked about before on the in the targeted therapy than you were if you were just conventionally treated. So again, taking good care of our patients' cardiovascular risk factors and using medications that we would normally use in these patients can be a benefit. What about ablation? Well, there have been several randomized trials looking at ablation now as first-line therapy for AF. It's still not in the guidelines yet. It's a consideration, but not necessarily 1A. But it is. There have been several studies all showing a benefit on recurrence of atrial fibrillation, and so these were trials that were published several years ago. But this is the most recent, one of the most recent trials, STOP AF, using the cryo balloon, where you see 75% versus 45% freedom from atrial fibrillation. And then symptomatic atrial fibrillation, similarly, see a similar benefit on risk. And so the current practice is that, for the ACC, HRS, 2014, 2019, and the ESC guidelines, it is a class 1 indication for symptomatic AF refractory or intolerant to antiarrhythmic drugs. And as I said, class 2 for initial therapy for symptomatic paroxysmal atrial fibrillation gets a 2A, and persistent 2B. So it's not a 1 yet, but there is some data suggesting that at least recurrences are less. And if we believe that these recurrences are related to outcomes, then perhaps it could be a benefit. And one of the trials that was one of the biggest trials, I think, has done really well because there was ILRs implanted in these patients, and there really was no crossover. And again, it was a cryoballoon study, early AF. And they really, sorry about that, they really made a goal of complete suppression of AF, both in the antiarrhythmic drug arm and with ablation. So they really gave them a fair test of the two modalities. And then they had an independent committee review and approve crossovers. And they assessed quality of life, and adverse outcomes were low in both treatment groups. And these are the results. The freedom from any recurrent AF on a ILR was greater than 30 seconds, was significant. 60% with ablation. And again, these are looking for really short duration. And we talked about, well, what does that mean? We're not really sure at this point, but it definitely is reduced. And then when we look at the secondary endpoint, which is probably more clinically useful, freedom from symptomatic AF, you again see a significant benefit. And in addition, you can probably get even better benefits if you combine ablation and risk factor modification. And again, these are data from the ARREST AF study, again from Prash Sanders' group, showing that if you look at single procedure AF survival in a control group versus those that had their risk factor managed, it's a marked difference. And multi-procedure AF-free survival, so doing several procedures as we often do, you can get a pretty high AF-free survival in this group of patients. And so again, looking at the BMI in these patients, in the control group, it was 31.8, and in the risk factor management, it was 29.1. So not huge amounts of weight loss, but those can, just even that small amount seem to have a benefit in this study. And then as far as long-term effective goal-directed weight management in an AF cohort, the amount of weight that you lose is definitely proportional to the benefits. So even though overall you don't see a marked increase, you don't see a marked difference in the BMI between these two groups, if you separate them out into the amount of weight loss that was lost, it seems like losing somewhere between 3 to 9% or less than 3% basically gets you to the same place over here with ablation freedom. It gets you to a better place if you lose a little bit more for total AF freedom. But really it's those who have a substantial amount of weight loss that actually seem to have the most benefit. So again, there's a continuous association between weight and AF, so it makes sense that the more weight that you lose, probably the less likely you are to recur. So this has been incorporated into guidelines and the ESC guidelines. It's a comprehensive AF risk management is definitely recommended at this point. Hypertension, as we talked about, physical activity. I didn't talk much about obstructive sleep apnea. Again, studies on that are not as clear. There's only been one randomized trial looking at obstructive sleep apnea treatment with CPAP, and really didn't have enough AF events to really show a benefit, but there was no benefit in that trial. Alcohol, we've talked about that. Hyperlipidemia, again, not a lot of data on that being beneficial. Smoking cessation, smoking is a strong risk factor for AF. Overweight, as we talked about, and glycemic control. There are several studies suggesting diabetes is related. And actually, we've done some studies looking at hemoglobin A1C, and patients with higher hemoglobin A1Cs are more likely to have persistent AF. So again, optimizing all these risk factors. And the other thing is, we talked about what anticoagulation can do in early AF that's detected by screening, and it wasn't very strong or impressive. So really, what about impacting outcomes beyond AF recurrence and burden, hard outcomes with risk factor modification? And in this study, in the women's health study, we looked at heart failure. And so we took all the women, and this is Neil Chatterjee's work, he's at the University of Washington now. We took all the women in the women's health study, and over 20.6 years, there were 1,500 patients who developed atrial fibrillation and 687 who developed heart failure. And so if you had atrial fibrillation, your risk of developing heart failure in this really healthy cohort without cardiovascular disease was almost 10-fold higher. And it didn't matter whether it was heart failure with reduced ejection fraction or heart failure with preserved ejection fraction. And this has been shown in the Framingham Heart Study and other studies as well. And when you look at the mortality that's associated, if you developed heart failure, you have higher mortality, you have higher cardiovascular mortality, and we even found a higher risk of myocardial infarction, and that does need to be replicated. So what about risk factor modification? And we found that, if you modify diabetes, smoking, obesity, and hypertension, which seem to account for 62% of the heart failure events, you could lower your risk of atrial fibrillation. So again, looking at the individual risk factors, you can see each of their associations. Smoking was a strong risk factor, body mass index, systolic blood pressure. And again, these are all in women with atrial fibrillation, their risk for heart failure. And then there are some things that we can't modify. Age, chronic kidney disease is not as modifiable, and incident coronary heart disease, we can do this through risk factor prevention, but once it's developed, it isn't necessarily modifiable. So if you look at putting all of these together and you look at the hazard ratio for developing incident AF, if you have optimal blood pressure, optimal BMI, no diabetes, and no smoking, the hazard ratio for developing for heart failure in patients with atrial fibrillation was 0.14. So marked reduction in heart failure risk for favorably modifying risk factors, perhaps. And again, this is just showing associations. It's not a randomized trial, but it is promising. And these are also data looking at optimal blood pressure, trying to say where that optimal blood pressure line is. And again, suggesting that it really is at sort of a almost normal blood pressure level. So really even just these small high levels of blood pressure are associated with adverse outcomes in patients with atrial fibrillation. So not only does it lead to atrial fibrillation, but it's associated with adverse outcomes. And you can see all of them here. And then there was one study that looked at, well, can we actually, modify people's blood pressure after catheter ablation and see a benefit? And this study did not show a benefit. And again, it was a small study, but in this group of aggressive blood pressure control, and they did see aggressive blood pressure control, they did not see a marked benefit in AF recurrence. And again, you can see how small it is. It's a really small study. But there looked like there could potentially be some benefit in those who are over age 60. So lifestyle recommendations in the AF guidelines, again, for patients with AF, it's a class 1 recommendation to modify their weight. And in the ESC guidelines, a number of recommendations, not just for weight, but also for blood pressure control, class 1, and also alcohol, class 2A, physical activity, class 2A, OSA, they say, is class 2A. So number of recommendations for us for risk factor management. And finally, I just want to talk about the EAST trial, which again, kind of turned our practice around a little bit over the last couple of months. But there was a total of 2,789 patients who had an AF diagnosis within 12 months of enrollment. And they were randomized to early rhythm control or usual care across 135 sites in 11 European countries. And patients had to have one of the following criteria. They had to be either older than age 75 years of age, or previous transient ischemic attack, or two of the following. They had to have two of the following risk factors for stroke, basically. So this was a higher risk population. It wasn't just all comers with atrial fibrillation. And this shows you the demographics. The mean age was 70, so it was an older population. They too were very successful enrolling women, 46%. And many of these had persistent atrial fibrillation at baseline, just like we found in the Vital Rhythm study. And they weren't just randomized to ablation, they were randomized primarily to antiarrhythmic drugs. And again, there hadn't been, and we sort of had thought there wasn't much benefit besides symptom control with antiarrhythmic drugs, but they were randomized to a whole host of them. The most likely ones were actually flecainide in this population. And what they found was that there was a benefit on a primary outcome that involved death from cardiovascular causes, stroke, hospitalization with worsening heart failure, or acute coronary syndrome. And that was about a 20% reduction in risk. And when you look at the individual endpoints, most of it had to do with, there was a benefit on death. There was also a benefit on stroke. And again, these were patients that were optimally anticoagulated. So perhaps rhythm control can get us somewhere beyond where we are with just oral anticoagulation. And again, hospitalization for worsening heart failure also showed a trend. So in summary, cardiovascular risk factor and lifestyle modification are critical for both prevention and management of atrial fibrillation. Management of comorbidities also improves maintenance of sinus rhythm and regression of persistent paroxysmal atrial fibrillation. And risk factor modification should be used as an adjunct to catheter ablation. It reduces AF recurrence and persistence, and may also reduce cardiovascular mortality in patients with AF. There should be greater emphasis on early treatment with rhythm control strategies is emerging. And so again, there are another number of studies here, one of which I'm on the steering committee for, where we are sort of doing the same experiment, but with dronedarone. And John Piccini is running that study, and it's being funded by that Sanofi, but also in concert with AHA, to look at the long-term consequences of AF. And to make an impact on morbidity and mortality, there must be a more comprehensive focus beyond stroke prevention. And it's needed early in the disease process. And the recent trials of screening suggest that this is going to be important for screen-detected AF as well. So I want to thank you for your attention.
Well, thank you very much, Christine, for this excellent and very comprehensive talk. You showed a lot of information about primary and secondary prevention in atrial fibrillation patients. So maybe we can divide the questions in these two scenarios. So let's talk first about primary prevention patients. that, as you know, means patients with maybe cardiovascular risk factors, right? And higher risk to present atrial fibrillation, but without any document of the arrhythmia. So you showed us a lot of information about cardiovascular risk factor control to decrease the possibility to develop atrial fibrillation. But how are you following those patients to be sure that you are getting that goal, right? Because remember that those patients are maybe asymptomatic, right?
Right.
So how to be sure about it? Because that doesn't mean that you have to screen those patients what about how long time to screen those patients? What kind of technology are you using to do that?
Yeah, no, those are great questions. And I think that, a lot of that data is from epidemiologic studies where, we don't have monitors in patients and we don't screen. And so these are all clinically detected atrial fibrillation episodes. But as I presented earlier, there really isn't any data yet that what we can detect by screening has a major impact on risk, or that we can modify that impact on risk. I mean, there's a couple of other studies, as you know, in pacemaker patients that are ongoing. And so the data is not all in. But at this point, I think we're also doing a pretty good job of detecting atrial fibrillation, maybe better than had been done previously. And I think, the stroke stop study kind of showed that, because they showed a large number of people that were in the control group that actually got anticoagulation over time, even though they weren't in the screening group, and they actually received a diagnosis of atrial fibrillation. So I think there's more awareness, and I think that's where screening can help too, because it increases awareness. So to answer your question, at this point, no, we really are just kind of looking for clinical AF in the ways that we normally do. But you're absolutely right. It would be great to have a study that actually was able to monitor patients and look long-term at that impact on outcomes. And, the investigators in the stroke stop study, may be able to do that. I mean, they just had that 2-week monitor. The loop study, they have, ILRs in those people. So if they were able to collect risk factor information, it would be really great to understand how that impacted asymptomatic episodes of AF.
Okay. There is a question here related with the previous question also about in terms of mobile health apps, right? How to use this information to be recorded or to be connected with the clinical record that we use in different hospitals, and how to establish a bidirectional communication with patients, because it is not just about recording, it is just about talking to the patient, what we are recording and what to do, how to become actionable things after you are getting that information.
Yeah, no, it's a great question. And I think, we're all struggling with that. There are definitely, some of the device, both the Apple Watch and Cardia have sort of developed connections with with Epic, which is one of the major EHRs in the United States. Whether that's used in a lot of systems, I know that we don't necessarily routinely. We can now upload some of our recordings, but the problem is that sometimes the patients still have to send them to you. You have to record them. You have to upload them. You get them through email. It's sort of a little bit like what we dealt with in the early days of remote monitoring. We were really scared about that, that all this information was going to come to us, and how are we going to manage that? And now it's even that on steroids, perhaps, maybe not with the same, seriousness with each alert. But it is a good question. And I hope that all these mobile app companies are thinking in that direction, because if they really want clinical uptake of their devices, they need to do the studies to show that it, is clinically, has good sensitivity, specificity, and I think that, they are doing those kinds of studies, but also thinking about ways to integrate it easy into the medical record. And I'm not sure that exists today.
Yeah. So following with the questions related with digital health, there is another one here. What is the role? Well, its role of the digital health to promote compliance of the patients to cardiovascular risk factors control? Because you show a lot of evidence demonstrating the benefit, but obviously you have to be compliant with that,
Right.
to get the goal. So what kind of technology are you using to do that?
So there was an interesting study that was published, I think now 2 years ago, called the MAPA study, where they actually used an app that not only, was able to help with the CHA2DS2-VASc score and other things, but also, make people, tell people that they need to lose weight, keep track of diaries. And it actually showed a real benefit, particularly on recurrence of atrial fibrillation. It was like a composite endpoint, but on recurrence. And so there are a number of things, the Europeans are using this telecheck, where they use the AF apps to prepare for the visit. And then you can also, there are a number of apps that, are utilized for weight loss and hypertension management. And so it'd be great to really have an integrated app that managed all of those risk factors, or helped you manage those risk factors, or keep people on track. That's the kind of research that, I don't specifically do myself, but is really important. And of course, it's going to work for coronary disease and other diseases. So I am sure that we are going to see that kind of technology. At this point, we use automated blood pressure cuffs at home and things like that, and scales and all of that, but we don't necessarily have a mobile technology that integrates all of that we're using at Cedars. But, I hope that something like that occurs, because it'd be useful.
Yeah, you mentioned that a very important concept for clinicians today that is related with progression.
Yeah.
So obviously, before we were thinking about avoiding stroke, obviously that is very important. But nowadays we are talking about not just avoiding stroke, but also avoiding progression, because obviously it's related with worse outcomes, etc.
Right.
So you have maybe one option is following AFib burden.
Mm-hmm.
The problem is, again, how to do that?
That's really hard. Yeah.
Because every 3 months, with a 24 hours Holter test, we know that it is not enough. But I think it's not really clear what is the best method. Is ILRs, is Holter test, is Apple smartphone apps, etc. So how are you doing in your practice that?
Yeah, I think that, I think most people are still using like a patch intermittently to see what burden is, but you're absolutely right. That is just a snapshot. And, unfortunately, the apps at this point can't really measure burden accurately, because the way that they detect AF is through intermittent screening. An intermittent screening of the irregularity of the pulse. So it's not even like a constant screening. And so I know that they're working on that type of technology, but I imagine that the battery life of these things or the memory of these devices aren't compatible yet with documenting burden. But obviously something that was a continuous monitor that was able to detect atrial fibrillation and record its duration would be what you would need. And we just don't have that right now. So often we'll use a surrogate, which is a 2-week monitor, hoping that 2 weeks is something that is representative of the patient's burden. But in general, we're just looking for patients who all of a sudden, they show up in your office and now they're in persistent AF. That's the way most of the time it happens, and unless you're following them really carefully, after ablation, a lot of times we will follow patients looking for asymptomatic atrial fibrillation because it is more common after ablation. But, in general, for clinical AF, not necessarily. If the patient says they're doing good and they don't have symptoms and they come to your office and they're in sinus rhythm, we don't go looking for it a lot. And because we don't really know what to do if we found it.
Yeah, so let's talk about the same question, but in another scenario, because you presented also at the end of your talk 2 options for treatment, right? So first choice, catheter ablation for maybe younger patient, maybe, patients without cardiovascular risk factors, that is fine. But there are another kind of patients, like they included in East Daphne study, that it was older patients with cardiovascular risk factors, in which it is very important to be sure that those patients are on sinus rhythm, independently if you are putting the patient on antiarrhythmic drugs or asking for ablation, right? But it seems to me for this study it was very important how you follow up the patient, right? Because you have to change your treatment choice if you were proving that it is not enough, that the patient is still having recurrences to optimize survival, hospitalization, et cetera, et cetera. So how to do that? Because it seems to me that every patient that is coming to you, to us, with similar population, you are thinking that maybe you have to follow these patients carefully, continuously. So how are you doing that? So you are testing.
It's hard, the East trial, it was interesting, the ESC guidelines came out the same meeting that the East trial came out. And, that was tough because all the ESC guidelines basically is based upon symptoms, right? And, most of the treatment of atrial fibrillation is directed towards quality of life and symptoms. And that's how we've been practicing now for the last 15 years. And this trial suggests that maybe it's not just all symptoms and maintaining sinus rhythm. Maybe there are some hard outcomes that if you follow a patient population long enough, that you will see a benefit if you try to maintain sinus rhythm. So it is, and you're right, they're the older patients that often we would probably treat with rate control because, we think about the proarrhythmic effects of antiarrhythmic drugs. We think about the, risks and complications of ablation. And now we're faced with this study that says, well, we did antiarrhythmic drugs in these patients and we treated some of them with ablation and they did better. So I think it is impacting, it's impacting my practice. I really want to see what the new guidelines come out. I know that they're in the process of putting together those guidelines, or putting together the guideline committee for AHA and ACC and HRS. But, really thinking about how we incorporate that into our practice, because you're right, it wouldn't be just one and done, right? And so you don't just get them in sinus rhythm and say goodbye. You would have to keep following them and making sure that they were in sinus rhythm. And you actually saw in East that a lot of the patients who were randomized to control actually were in sinus rhythm. So even on that, there was a benefit. So yeah, it's a new way of thinking about it.
Okay. So last question, because you are going to an end of the activity, is formulated by our cardiovascular imaging director, Dr. Medina, who is asking about DCAF2 that was recently published. Yeah. And what is your opinion about it, and what are your thoughts in doing radiofrequency catheter ablation in patients with severe late gadolinium enhancement on both atria?
Yeah, the DCAF2 was a little disappointing, that it didn't show really a benefit of, we previously, clearly, the amount of fibrosis at least in observational studies, had to do with, the impact of ablation, the outcome. But then when they randomized to that and tried to use it to guide the ablation, it didn't seem to have a benefit. I haven't seen it in publication yet. I don't know if it has been published yet. I haven't seen it. But, obviously that's really when you get to really dive down into it. But yeah, I think that ablation, we have to be smart. If you do have that kind of amount, we know that amount of LG in the atrium is associated with worse outcomes. We know that. And we know from DCAF2 that if you target it, it doesn't really help. So maybe we really shouldn't be bringing these patients for ablation. So whether it could be useful to eliminate people from ablation hadn't really been tested, but I think it's an important hypothesis.
Yeah, so maybe we have to include in the definition of progression, not just following AFib burden, but also following fibrosis amount.
Yeah.
Right? Because if the patient is increasing the amount,
right.
Fibrosis, maybe we're not getting the goal, to prevent progression. We are maybe not control enough the cardiovascular risk factors, or otherwise the patient has another disease,
Right. Yeah.
Genetic, who knows? What is your
You're right. You're right. There's lots. Yeah, lots that we need to realize instead of just accepting it. We have to probably intervene earlier in the disease process, and there's lots of ways that we can potentially follow that disease process beyond just AF itself.
Well, okay. Thank you very much.
Thank you.
It was an excellent talk, as always, and thank you very much for joining us in this kind of activity that is very important for all of us in our institution and our region. Hope to see you again in another webinar.
Yes, hope so, or even in person. All right, take care, Luis.
Muchas gracias a todos los que se unieron a esta actividad. Gracias por su participación y de nuevo un agradecimiento a Medtronic por haber soportado esta actividad. Nos vemos en una próxima oportunidad. Hasta luego.